This is a patient with a slightly decentered Symfony lens. She's also a little bit hyperopic and not happy with the outcome in the size. She's had extensive YAG laser capsulotomy and has been referred for a lens exchange. Here we're going to place a pars plana trocar infranasally. We're going to place a second pars plana trocar supratemporally, and you can see the way I angle in here to create a self-sealing incision and see the tip of the trocar in this pupillary space. I'll now place the infusion cannula and put my paracentesis where I can use them ergonomically. I'm going to score my clear cornea incision here with the super blade and put viscoelastic in the anterior chamber to stabilize it. I'll now make my main incision with the 2.75 keratome. And now I'm going to use dispersive viscoelastic on a 26 gauge LASIK cannula to try to get into the space where this haptic is. You can see that there is extensive anterior capsule fibrosis here just beyond the optic. I'm trying to open this up and free up the anterior capsule here. We're going to make another incision so we can work our way around from a better angle. And when I get to about here, I can see that the anterior and posterior capsule here are fused, and about on this side here are also fused on the other side of the haptic and wrap around behind the optic of the lens, fusing the anterior and posterior capsule together. So I'm going to want to try and dissect this open, but it's pretty well stuck together. So here I'm going to see if I can free up this haptic here, and it doesn't seem like it's too socked in. Looks like I'll be able to get that out, but you can see on the right supratemporal side of the patient, the anterior and posterior capsule are fused behind the implant. So I'm going to try to dilate the capsular bag on the other side where I know I can open it up to about this point here, where they start to fuse the anterior and posterior capsule and swing around behind the optic of the lens. Now I'm going to try to free up this haptic and remove it from the capsular bag, and this does slide out pretty easily. I'm now going to see if I can extricate the other haptic, but this is pretty socked in this area where the anterior and posterior capsule are fused. So I'm going to see if I can open that up a little bit with some viscoelastic. And now I'm going to grab this haptic with a micrograsper and see if I can dissect it out of the capsular bag fornix here. And I'm going to have to sweep away this fibrosis over this thickest part of the haptic. But it's still, even once I get past that, pretty stuck. So I'm going to keep sweeping and trying to get this haptic freed up from the capsular bag fornix without taking the capsular bag with it. And here it looks like I'm in pretty good shape. I've got the lens completely loosened up out of the capsular bag, free in the anterior chamber. So now I can go ahead and cut this in half. I'm going to leave a little hinge, about 10% of the peripheral lens, so that I can cartwheel the lens out of the anterior chamber without worrying about losing half of it behind into the back of the eye. So this way it'll all come out in one piece. We'll now go ahead and do some pars plana vitrectomy to clean things up. And this will take care of any vitreous that's present in a very controlled fashion. Now we're going to try to break the adhesions between the anterior and posterior capsule, and you can see they're pretty tenuous. Right here, there's pretty well socked together. There's a lot of fibrosis here. And I don't want to tear the anterior capsule if I can avoid that. So I'm going to work from each side and try to break the adhesion, which seems to be stiffest right here. So I'm going to come with a 27 gauge cannula and cohesive viscoelastic now and see if I can break this. And right there you could see it break. And now I think I've separated the anterior and posterior capsule pretty much 360 degrees. And I'm just sweeping around to make sure that there are no adhesions or strands of fibrosis. So I can go ahead and put the lens in the capsular bag remnant. The posterior capsule here is pretty well defined, so I think we can use it as a backstop. And now I'm going to inject a 3-piece Softport A0 lens, and I'm going to try to hug right under the anterior capsule rim and inject this lens so it opens up right under the anterior capsule rim, and the haptic goes into the equator of the capsular bag fornix. I'll now dial the other haptic in very carefully, making sure it doesn't go beyond the posterior capsule. It stays above the posterior capsule and just under the anterior capsule. I'll rotate the lens a little bit here, and it looks real good, real well supported. When I sweep here, however, I can see there's a little vitreous strand. It appears right here. So I'm going to come out and I'm going to take a Lewicki anterior chamber infusion. Instead of using pars plana infusion, I'm going to shift to anterior infusion and come in through the limbus with my vitrector and see if I can cut the strand. But it's a blind cut, so I'm going to put in some triescence, diluted triescence, to stain the vitreous. And now I'll come from the pars plana with anterior infusion, and you can see the stained vitreous here very nicely. And it shows me what I'm trying to remove, so this isn't a blind procedure. So I'm going to come from behind the lens and remove as much as I can. And then after this is done, I'll come in front of the lens through the paracentesis and finish cleaning things up. And I like to do this move back and forth from anterior to posterior with both infusion and vitrectomy to get the most efficient cleanup. I'll sweep now and see that that strand is gone. I'm going to rotate the lens within the capsular bag fornix just a little bit to get it to center really nicely. You can see the posterior capsule opening here. The anterior capsule is a little bit larger than the optic in some areas. We can remove our trocars, firm up the eye a little bit with some BSS, and the case is completed. Thank you for your attention.